Hi everyone, this is Doc Ina, and welcome to my lecture on PID and Pelvic TB. The main reference for this lecture is Comprehensive Gynecology, 7th edition, Chapter 23, Genital Tract Infections. So, this lecture is of two parts. First part is PID and the second part is Pelvic TB. So, for PID, we will be discussing the definition, etiology, the risk factors, signs and symptoms, the diagnosis, treatment, and the sequela. For pelvic TB, we will discuss the etiology, signs and symptoms, diagnosis, and treatment. So let's first start with pelvic inflammatory disease or PID. PID or pelvic inflammatory disease is the infection of the upper genital tract not associated with pregnancy or intraperitoneal pelvic operations. This is a polymicrobial infection that is a mixture of aerobic and anaerobic bacteria, clinically appearing as a complex infection. It may include infection of any or all of the following anatomic locations: endometrium, oviducts, the ovary, the uterine wall, the uterine serosa and broad ligaments, and the pelvic peritoneum. The oviducts or the fallopian tubes are the most commonly affected by PID. Acute PID results from ascending infection from the bacterial flora of the vagina and the cervix in more than 99% of the cases. Acute PID is rare in the woman without menstrual periods, such as the pregnant, premenarcheal, or postmenopausal woman. In less than 1% of cases, acute PID results from transperitoneal spread of infectious material from a perforated appendix or intra-abdominal abscess. Hematogenous and lymphatic spread to the tubes or ovaries is another remote possibility. PID is extremely rare in women who are not sexually active or who are amenorrheic. When PID is found in a postmenopausal woman, then the associated conditions are as follows: genital malignancies, diabetes, and concurrent intestinal diseases such as diverticulitis, appendicitis, or carcinoma. In many cases, no causative organism is found for PID. However, the two classic sexually transmitted organisms that are associated with PID are Neisseria gonorrhea and Chlamydia trachomatis. Let's first tackle Neisseria gonorrhea. Once the gonococcus ascends to the fallopian tube, it selectively adheres to the non-ciliated mucosecreting cells. However, most damage occurs to the ciliated cells, most likely because of an acute complement-mediated inflammatory response with the migration of polymorphonuclear leukocytes, vasodilation, and transudation of plasma into the tissues. This robust inflammatory response causes cell death and tissue damage, leading to scarring and tubal adhesions. So this is how pelvic inflammatory disease looks like under the microscope. The picture on the left is an acute salpingitis with a mixture of neutrophils, lymphocytes, and plasma cells in the fallopian tube, destroying some of the epithelial lining. The picture on the right is also an acute salpingitis showing dilatation of the fallopian tube and blunting of the papillary fronds. The other etiological agent that's most commonly associated with PID is Chlamydia trachomatis. Chlamydia trachomatis is an intracellular, sexually transmitted bacterial pathogen. Chlamydia may remain in the fallopian tubes for months after initial colonization of the upper genital tract. Primary infection appears to be self-limited, with mild symptoms and little permanent damage. However, repeated exposures to chlamydia, such as may occur in asymptomatic and treated Chlamydia trachomatis cervical infection, may lead to an autoimmune response that causes severe tubal damage, even if Chlamydia trachomatis is no longer present. The most common aerobic organisms are non-hemolytic Streptococcus, E. coli, Group B strep, and coagulase-negative Staphylococcus. Anaerobic organisms tend to predominate over aerobes, and the most common anaerobic organisms are Bacteroides species, Peptostreptococcus, and Peptococcus. Anaerobic organisms are almost ubiquitous in pelvic abscesses associated with acute PID. So what are the risk factors for developing a PID? So first is age at first intercourse, marital status, and the number of sexual partners. The more sexual partners or the more promiscuous a person is, then she is more at risk for PID. So these are the signs and symptoms of pelvic inflammatory disease. So basically, we have the minimum criteria, the additional criteria, and the definitive criteria. For the minimum criteria, you only need to fulfill one out of the three. So the three criteria here would be lower abdominal tenderness, adnexal tenderness, cervical motion tenderness. So just one out of those three will be sufficient to diagnose PID using the minimum criteria. So we'll go through this slide again later in the lecture. Lower abdominal and pelvic tenderness during examination is the hallmark of acute PID. The most frequent symptom of the acute PID is new onset lower abdominal and pelvic pain. Pain is characterized as diffuse, bilateral, and usually described as constant and dull. It may be exacerbated by motion or sexual activity. The duration of pain is usually less than 7 days. Now, it is important to remember that up to 50% of women with tubal damage never experience any symptoms consistent with PID. So, in a PID, we sometimes note the Fitzhugh-Curtis syndrome. And what is this? This is a syndrome that develops from the transperitoneal or vascular dissemination of the gonococcal or chlamydia organism to produce the perihepatic inflammation that you see here on the right. So these are the violin string adhesions between the anterior peritoneum and the liver capsule. And this is what we call the perihepatic inflammation secondary to PID. Now, not all patients with PID manifest with Fitzhugh-Curtis syndrome. How do we diagnose PID? One way of diagnosing PID is direct visualization via laparoscopy, and this is the most accurate method of diagnosing acute PID. Laparoscopy offers the additional advantage of concurrent operative procedures such as lysis of adhesions, potential drainage of an abscess, and irrigation of the pelvic cavity. Acute PID should be included in the differential diagnosis of any sexually active woman with pelvic pain. Now we can also examine the endocervical mucus for inflammatory cells and perform the NAAT for Neisseria gonorrhea and Chlamydia trachomatis. The presence of an increased number of vaginal white blood cells is the most sensitive laboratory indicator of acute PID. Other methods to diagnose PID are the following. We can do endometrial biopsy. However, this is not really recommended because of its invasive nature. We can do a transvaginal ultrasound, and this is useful in documenting an adnexal mass. We can also do MRI, especially if there is equivocal findings in some of the methods that were used to initially diagnose PID. However, MRI is expensive and has limited acute availability in some locations. Now, as I've said, we have the different criteria for the diagnosis of PID. So usually we just use the minimum criteria, which I said you just have to fulfill one out of the three. It could be the lower abdominal tenderness, adnexal tenderness, or cervical motion tenderness. We have the additional criteria, which are the following: oral temperature of greater than 38 degrees centigrade, abnormal cervical or vaginal discharge or mucopurulent vaginal discharge, presence of abundant WBCs on microscopy of vaginal secretions, presence or elevated erythrocyte sedimentation rate or ESR, elevated C-reactive protein or CRP, and a laboratory documentation of cervical infection with Neisseria gonorrhea or Chlamydia trachomatis. Then lastly, we have the definitive criteria for diagnosing PID, and we have the following: a histopath evidence of endometritis on biopsy, transvaginal sonography or MRI showing thickened fluid-filled tubes with or without free pelvic fluid or tubo-ovarian complex, laparoscopic abnormalities consistent with PID, and although initial treatment can be made before bacteriologic diagnosis of chlamydia trachomatis or Neisseria gonorrhea infection, such a diagnosis emphasizes the need to treat sexual partners. Now we go to the treatment. The two most important goals of the medical therapy of acute PID are the resolution of symptoms and the preservation of tubal function for fertility. Antibiotic therapy should be started as soon as the diagnosis has been made. Early diagnosis and early treatment will help reduce the possibility of long-term sequela of the disease. Women who are not treated in the first 72 hours following the onset of symptoms are 3 times more likely to develop tubal infertility or ectopic pregnancy. In the management of acute PID, do not forget to treat and educate also the male partner for the prevention of the disease. Also, the recurrence of the disease, including the use of proper contraceptives, which help reduce the rate of upper genital tract infection. Because most cases of PID are polymicrobial, broad-spectrum antibiotic coverage is indicated. Empirical antibiotic protocols should cover a wide range of bacteria, and this includes Neisseria gonorrhea, Chlamydia trachomatis, anaerobic rods and cocci, gram-negative aerobic rods, and gram-positive aerobes. Now, in the treatment of PID, we have the outpatient regimen and the inpatient regimen. So for outpatient, these are for patients that we did not confine in the hospital. So for the outpatient treatment, we have the following options. And these options or recommendations are dictated by the Center for Disease Control. Now we have option 1 is ceftriaxone 250 milligrams IM single dose, cefoxitin 2 grams IM single dose plus probenecid 1 gram per RM single dose. Other parenteral third-generation cephalosporin such as ceftriaxone and cefotaxime plus doxycycline 100 milligrams per RM BID for 14 days with or without metronidazole 500 milligrams BID for 14 days. So if you notice, since this is an outpatient protocol, we don't give any intravenous form of antibiotics. It's either oral or intramuscular injection single dose. It is important to re-examine women within 48 to 72 hours of initiating outpatient therapy to evaluate the response of the disease to the oral or parenteral antibiotics. If the disease is responding well, then approximately 4 to 6 weeks after therapy, the woman should be re-examined to assess the resolution of clinical symptoms and establish a post-treatment baseline. So what are the indications of confining or admitting a patient with PID to the hospital? And here are some of those indications. Number 1 is if there's a surgical emergency or in the presence of an acute abdomen. The patient is pregnant. The patient does not respond clinically to oral antimicrobial therapy and therefore might need an intravenous antibiotics. The patient is unable to follow or tolerate an outpatient oral regimen. The patient has severe illness, nausea and vomiting or high fever. And the patient has a tubo-ovarian abscess on ultrasound. And here is the regimen for the inpatient. So for the inpatient protocol, we have the regimen A and the regimen B. Okay, for regimen A, our choices would be cefotetan 2 grams IV every 12 hours or cefoxitin 2 grams IV every 6 hours plus doxycycline 100 milligrams per RM or IV every 12 hours. The parenteral. So the next is regimen B. and this is composed of clindamycin plus gentamicin. So clindamycin, it's 900 milligrams IV every 8 hours, and gentamicin with a loading dose of 2 milligrams per kilograms of body weight, followed by a maintenance dose of 1.5 milligrams per kilogram every 8 hours. The alternative parenteral regimens would include ampisulbactam 3 grams IV every 6 hours, plus doxycycline 100 milligrams per RM every 12 hours. And one trial has demonstrated high short-term clinical cure rates with azithromycin, either as a monotherapy for 1 week or combined with a 12-day course of metronidazole. With IV protocols, the CDC recommends that IV antibiotics be continued for at least 24 hours after substantial improvement in the patient. When the woman has a mass, we add ampicillin to clindamycin and gentamicin. For patients without a mass, we switch to oral antibiotics when the symptoms have diminished and the woman has been afebrile for 24 hours. In both regimens, doxycycline is continued for a total of 14 days. Regimen A is a combination of doxycycline and IV cefoxitin. It is excellent for community-acquired infection. Doxycycline and cefoxitin provide excellent coverage for Neisseria gonorrhea, Chlamydia trachomatis, and penicillinase-producing Neisseria gonorrhea. Cefoxitin is an excellent antibiotic against Peptococcus and Peptostreptococcus species and E. coli. Regimen B, on the other hand, is a combination of clindamycin and gentamicin, as I've already mentioned, and this provides excellent coverage for anaerobic infections and facultative gram-negative rods. It is preferred for patients with an abscess, IUD-related infection, and pelvic infection after a diagnostic or operative procedure. So in other words, if the patient comes to you with a ultrasound finding of a tubo-ovarian abscess, then automatic, you give regimen B. Parenteral antibiotic therapy may be discontinued when the woman has been afebrile for 24 hours, and oral therapy with doxycycline should continue to complete 14 days of therapy. So when do we do surgery for these patients with PID? Operations are restricted only to the following. For those patients with life-threatening infections, patients with ruptured tubo-ovarian abscesses, patients for laparoscopic drainage of a pelvic abscess, those with persistent masses, and some older women for whom future childbearing is not already considered, and removal of a persistent symptomatic mass. So what is the difference between a tubo-ovarian abscess and a tubo-ovarian complex? An abscess is basically a collection of pus within a newly created space, whereas a tubo-ovarian complex is a collection of pus within an anatomic space created by the adherence of adjacent organs. So for example, if you have a collection of pus between the space that's created by the adhesion between the uterus and the ovary and the fallopian tubes, then that's what you call a tubo-ovarian complex, because complex means that there is the involvement of more than one structure. Since clindamycin is stable in the abscess environment, a combination of clindamycin and aminoglycoside is considered the standard for the treatment of a tubo-ovarian abscess. Now, for the sequela, ectopic pregnancy, chronic pelvic pain, and infertility are the most common sequela for PID, and these are usually secondary to scarring and adhesion formation. Following acute PID, the rate of ectopic pregnancy increases 6 to 10-fold, and the chance of developing chronic pelvic pain increases 4-fold. The incidence of infertility varies widely, can be as low as 6% or as high as 60%, depending on the severity of the infection, the number of episodes of infection, and the age of the woman. Approximately 10% to 15% of pregnancies will be ectopic after laparoscopically mild to moderate PID, and almost 50% after a severe PID. 4% and 13% of women are infertile or undergo an operative procedure secondary to acute PID. Chronic pelvic pain may be caused by a hydrosalpinx, which is a collection of sterile watery fluid in the fallopian tube, such as you see here in this picture. A hydrosalpinx is an end-stage development of a pyosalpinx. Pain may result from adhesions and the resultant fixation of tethering of organs intended to have freedom of movement during physical activity, coitus, and ovulation. So for the second part, we talk about pelvic tuberculosis. Pelvic tuberculosis is secondary to infection with Mycobacterium tuberculosis or Mycobacterium bovis. Early in the course of pulmonary infection, the bacteria may spread hematogenously and the infection becomes located in the oviducts, which are the primary and predominant site of pelvic tuberculosis, much like PID. Subsequently, the bacilli usually spread to the endometrium and less commonly to the ovaries. Clinical symptoms and signs of pelvic tuberculosis are very similar to the chronic sequela of acute PID. And the predominant presentations of this chronic infection are infertility and abnormal uterine bleeding. Mild to moderate chronic abdominal and pelvic pain occur in 35% of women with the disease, and advanced cases are often accompanied by ascites. Some women may be asymptomatic also. Tuberculosis salpingitis may be suspected when a woman is not responding to the conventional antibiotic therapy, and the results of a tuberculin skin test will, of course, be positive. How do we diagnose pelvic TB? The diagnosis may be established by performing an endometrial biopsy late in the secretory phase of the cycle. And the classic findings on endometrial biopsy will be the following: giant cells, granuloma, and caseous necrosis that will confirm the diagnosis. Now, the distal ends of the oviduct remain everted, producing a tobacco pouch appearance on imaging studies. When the diagnosis has been established, the woman would have chest radiographic examination just to check if she has a pulmonary tuberculosis, IV pyelography to establish if there is involvement of the kidney or the ureters, serial gastric washings to see if there's involvement already of the GI tract, and urine cultures for tuberculosis to also to see the involvement of the genitourinary tract. Now, approximately 10% of women with pelvic tuberculosis have concomitant urinary tract tuberculosis. How do we treat pelvic TB? The treatment of pelvic tuberculosis is mainly medical. Initial therapy in a woman with newly diagnosed tuberculosis usually will include 5 drugs because of the emergence of multi-drug resistant organisms, and this will include isoniazid, rifampicin, ethambutol, pyrazinamide, and bedaquiline, Certuro. Multi-drug resistant or MDR tuberculosis is defined as infection from a strain of M. tuberculosis that is resistant to 2 or more agents, including isoniazid. The CDC has recommended starting a woman on a multi-drug regimen until the culture results yield specific sensitivity. Patients who have infection from MDR strains are usually kept on a 5-drug regimen. Operative therapy for pelvic tuberculosis is reserved only for women with the following: there's persistent pelvic mass, resistant organisms, if patient is already 40 years old and above, and endometrial cultures remain positive. So in summary, we talked about 2 topics in this lecture. We talked about PID and the other one is pelvic TB. Actually, they are very similar in terms of signs and symptoms. However, the treatment, of course, is different. For PID, we discussed how to diagnose and how to treat it whether it be an outpatient regimen or an inpatient regimen. And for the inpatient regimen also, we talked about the regimen A and regimen B. And then for pelvic TB, we talked about how to diagnose pelvic TB and the treatment of pelvic TB. That's it for my lecture. Thank you for watching this lecture, and please don't forget to subscribe in my YouTube channel and my WordPress site. Thank you.